Hello, and welcome to our collaboration between healthcare professionals and behavior analyst webinar. I'm Amy Cook, BCBA and Community Manager, and I want to go over a few things before we get started. First, you will all be eligible to earn one free CEU if you're watching this live and you complete a few requirements. We're going to share 3 keywords throughout the webinar that you'll need to jot down. After the webinar, I'm going to share an online form with you that you need to complete and type in those 3 keywords to confirm your participation. And a recording will be sent out to all registrants. However, only live participants are eligible to earn the CEU. So now I'm going to tell you a little bit about our story. Hi Rasmus is a mission-driven platform built to empower the people who care for children with autism, inspired by a father's journey navigating early intervention for his son Rasmus. We exist to ease the burden on care teams and help more children thrive. At our core is a data system designed for real world of behavioral health, where clinicians and caregivers can capture progress, document sessions, and stay focused on the child, not the paperwork. Every feature is guided by experienced BCBAs and supported by a team that partners with providers from the very first demo throughout the implementation and beyond. Trusted by behavioral health providers, school-based teams, and organizations nationwide, Erasmus adapts to fit your needs, whether you're a solo practitioner or a national enterprise org, so that you can deliver exceptional care at scale. We're on a mission to improve the lives of 1 million children with autism by empowering the professionals, caregivers, and educators, and all of you that are here today to support them every day. Okay, I'm now going to give you your first keyword alert. The first keyword is the word collaborate. I will also enter that word in the chat in just a minute. And I'm now so excited. I'm going to hand it over to our guest speaker, Dr. Linda Copeland, a developmental pediatrician and BCBA. We are so happy that you are here today. Thank you for being here. I'll let you go ahead and take it from here.
Thank you. I'm going to share my screen and bring up my PowerPoint and we'll get started. Okay, so you can all see the slides.
Yes, it looks great.
I'm thrilled to be here with Hi Rasmus and with all of you. I was fascinated to learn about all the wonderful mission of Hi Rasmus. And I'll be talking about collaboration between healthcare professionals and behavior analysts, because over my career, I've been integrating the field of medicine with behavior analysis. Okay, my slide is not advancing. Let's see. It advanced. Let me see if this will.
Try the arrow. Will the arrow button on your keyword forward work?
The arrow button on my keyboard. Yeah, it worked yesterday. I'm not sure why it's not working. Let's see if there's another way to forward the slides. Sorry for this technical difficulty. So I'm screen sharing.
Oh, I see. On the very bottom left, there's an arrow to the right, but gosh, that's pretty tiny. I don't know if you can see that. Yep, right there, I think.
I see it. Aha. Great. Thank you for that, Amy. So I have no financial disclosures, and I want to thank all these professionals for input I used from them for my presentation. So the biggest thing is that collaboration is a two-way team approach. And what I've noticed over my career is behavior analysts are often very eager to network with various health care providers, but healthcare providers haven't always understood the importance of collaborating with behavior analysts. I think that is gradually changing. And obviously, we know from our ethics with our CAS guidelines that we need to, as behavior analysts, consult medical professionals if we think a medical issue may be impacting our client's behavior. And sometimes a full medical clearance is needed before you actually start your behavioral intervention. And what I would suggest is try shaping the behavior of other health professionals in a respectful way if you find you're not getting the input and a reciprocity from them that you would like. And if you can show healthcare professionals how helpful you can be with their patients, then you're reinforcing them to include you. So I would say be persistent. And I recommend this book on behavioral consulting by Doctors G. Roy Mayer and Michelle Wallace. I and my colleague, Dr. Greg Buck, actually authored chapter 3 in the first edition of this book on interfacing and consulting with the medical profession. So some of what I talk about in my presentation today will be from that chapter. And here's an example. So this is an anecdotal example from Dr. Wallace. It was about a young man who was refusing to wear his prescribed leg splints. So the BCBA did a detailed history, consulted with the family and doctor who prescribed the splints, and determined that the young man was getting aggressive whenever the mother prompted him to wear the splints. But the splints had not been adjusted for his growth as he matured. And so they were aversive to him. So once the behavior analyst understood that, the first thing was to order new splints. And then a shaping program was done to gradually increase the duration that he'd wear the splints, reinforce him for that, and it was successful teamwork. And this is just an anecdotal case study, but I will give you some reference research articles about this kind of example. So BCBAs, I think, can help be coordinators of healthcare. Obviously, you want to know your client's medical history, who their doctor and dentist is, and importantly, make a referral for medical evaluation if you think it's needed. And it may be helpful to directly contact the medical personnel and explain why this referral is being made. So you can help inform both the family and the doctor on the magnitude and significance of any substantial changes that your data shows in the client's functioning. So for a physician, a low verbal client, a low verbal patient was low verbal a month ago, is low verbal again today. They may not see the decline in functioning that you see. And then be prepared to provide data. And I'll be talking about this more in the slides ahead. Okay, so obviously you want to know your client's medical treatment history. And I currently work part-time doing insurance review for ABA programs. And I find that fortunately, ABA companies are very good at documenting. They know the medical diagnoses, surgeries, injuries, illnesses, know the medications, also know the potential side effects of the medications or supplements, and if there's any significant changes in the overall health status of your client. Obviously, you want to know vision and hearing tests, their immunization status. If there's medical restrictions, I'll talk a little bit about that and some case examples, and their allergies. My colleague, Dr. Buck, and I also have a chapter on addressing medical issues published in Behavior Analysis in Practice. And a lot of what I'm going to be talking to you about comes from that article we published. So in the medical field, when a problem is not easily detected or observable, we may use the term that it's occult. And occult issues are obviously more likely in low verbal clients. So I'm going to give you some tips. Obviously, health is a huge area, and I can't just describe all the health problems that one of your clients may be experiencing, but I'm going to try and give you some tips about possible red flags of medical problems. And so here they are, and a lot of them are logical and common sense. Any changes in weight, skin changes, and be aware that the skin may be hidden by clothing. When I'm working in pediatrics, either with just young children or with people with developmental disabilities, I've often advised the parents, caregivers to, if the child's not feeling well and we don't have an idea why, is to unbathe them, undress them, bathe them, and really look them over from head to toe. Look for changes in breathing. There could be GI problems. There could be evidence that they're experiencing pain. And I particularly want to point out back arching, because unusual arching of the back is done to ease the pain of acid reflux, or what we call GERD. Are they having sleeping problems? Loss of interest in their most preferred foods and activities could go along with a lot of potentially serious things: depression, low thyroid hormone, or any kind of significant chronic illness. Look for unusual inattention, and especially this repetitive eye blinking and lip smacking. You might not always think about seizures with that, but there are seizures that can do that, as well as twitches and sudden loss of postural tone. I'll give you an example of that later. Is there poor focus and attention span? That could go along with a co-diagnosis of attention deficit hyperactivity disorder, or ADHD. If you have unusual problems in toilet training the child, that could be due to either urinary tract issues or GI tract issues. And GI tract, not only for bowel training, but the GI tract can impact the urinary system as well. And then look for any changes in mood and mental status and so forth for possible mental health diagnoses. Symptoms of discomfort can be misinterpreted in low verbal clients, and thought to be non-compliance. And changes in neurological status can also be misinterpreted. Okay, let me find that little arrow again. Also, there can be behavioral data that can be clues to a possible medical problem. So you want to look for, like, if there's gradual changes in motor function or adaptive function. One place you could see that is in this genetic syndrome, more common in young girls, called Rett syndrome. And in Rett syndrome, these young children go from having functional use of their hands to play with toys and manipulate objects to losing that ability and then getting into repetitive hand wringing that really interferes with them learning through manipulating with their hands. And they also get gradual gait problems where it gets more and more difficult to walk, and many times they end up in a wheelchair. So think of things like that. If there's progressive sensorineural hearing loss over time, it may not be immediately apparent, but that would make sense if there's decreased compliance with verbal directions, understanding verbal language. Get a hearing test. Anytime there's an undifferentiated behavioral function, and we see this, not infrequently in behavior analysis, think of one possibility is there could be a medical problem. Obviously, if there's rapid loss of cognitive or verbal skills, you can see that in a host of serious medical conditions like strokes, seizures, or severe mental health problems like psychosis or catatonia. There's this not uncommon genetic syndrome called Landau-Kleffner seizure syndrome, in which the presentation is a lot like autism, that the young children start losing their comprehension of spoken language that they had, and then they start losing the ability to talk, and they have very abnormal brainwave patterns. But just a reminder that even if you see some of these potential warning signs, they're not always the product of medical issues. And you also want to check for things like flawed data or some issue in your problem in how you're collecting the data. So bottom line, we want to know our clients. And I'm happy to say, as I do insurance reviews of children getting ABA services, that I see children with diagnoses other than autism getting the ABA when they need it. For instance, I've seen a number of children with Down syndrome make some nice progress with ABA. And one thing you want to be aware of, not only the current and past medical history, but what the children may be at risk for. And it turns out children with Down syndrome are at risk for a lot of significant health problems as they grow. And so much so that the American Academy of Pediatrics did a whole detailed recommendation of all the kind of health screenings and monitorings that children with Down syndrome need. And that reminds me that I should tell you that there's a website for an AAP article on care for Down syndrome. And I've included a handout. You'll get 3 handouts during this presentation, and 1 handout lists of several of the websites that I talk about in this talk. But you'll also get a reference list, and it'll reference the book on behavioral consulting by G. Roy Moyer and Dr. Wallace. Kids with Down syndrome frequently get hearing loss, and so much so that it's advised that they see an ears, nose, and throat doctor every 6 months for the first few years of their lives. And the majority of them end up needing surgery to put PE tubes in their eardrums. They can get low thyroid hormone, iron deficiency. They may have congenital heart disease, so they're screened for that right from birth. But less known is this condition called atlantoaxial instability of the neck. And that's where the neck bones high up in the neck are very unstable and can slip and can suddenly impinge on the spinal cord. And that is a neurosurgical emergency. So you want to know if your child with Down syndrome has this condition, and there's restrictions on their activities if they do. They shouldn't do extreme tumbling, somersaults, diving, things like that. They're at risk for celiac disease, and about 19% of children with Down syndrome are now noted to have autistic-like behavior, or may actually be given a diagnosis of autism as well. And there are other genetic disorders that I'm seeing more and more getting ABA services. This is a little boy with Cree-Duchenne syndrome. So on these less common genetic conditions, the primary care provider in the family may have fact sheets for you that can be very helpful. That not only, like I said, you want to know what health conditions these children are at risk for. And you could do a search engine to get more information. There's also this website that's on your handout for the National Organization of Rare Disorders. So now I'm going to give you some case examples and research studies that I promised. And the first is of a client whose self-injurious behavior was restricted solely to the context of radio playing, but only when they had an ear infection while the radio was playing. So every time they started this unusual self-injurious behavior, they saw the doctor, who consistently confirmed there was an ear infection, which was treated, and then the self-injury resolved. There can be occult seizures that are not obvious in children, and this can have a lot of impact. So my colleague Greg Buck had an experience with this child who had autism and who was making great progress in ABA. And then some very new and unusual behavioral problems abruptly started. And at the same time, there was dramatic slowing of progress. So Dr. Buck wisely made a neurology referral, or a primary care referral, who referred to a neurologist. The child was worked up, had an previously unsuspected seizure disorder. Seizure disorder was treated, and the child returned to good progress. Pardon me, I had a little frog in my throat this morning. And then I observed a case of a child who had unsuspected drop attack seizures, and they were mistaken for deliberate noncompliance and falling to the ground. But the clue to me when I observed the child was they made no attempt to break their fall. So be aware of things like that. Examples of health problems that can impact behavior. And this was a teen girl who was low verbal, had autism, and she was having a new problem of hitting at her eyes. The parents had taken her to an eye doctor several years before, and it was normal at that time. But they went back to the eye doctor, and to everyone's surprise, she had a rapid development of bilateral cataracts. And so she had cataract surgery, and the hitting of the eyes resolved. And then a young man, that case I was aware of with autism, he was pretty high functioning. And not surprisingly, his most preferred activity in the world was like screen time and electronics on the computer. And he would do that day and night. And so he had to be trained to enjoy activities outside, which that treatment was successful, and he had a much more balanced life. So the problem seemed resolved for about a year, but then it had a sudden reoccurrence. Yet this time, looking at the data on the functional assessment, he was particularly avoiding going outside. Hold on, I got a call. Sorry. Jennifer, I'm in the middle of a talk. Well, don't call me till after 10. Thank you. Bye. Sorry, I had reminded my sister not to do that, and she forgot. So back to this young man. So he was avoiding going outside during bright sunlight, but not, interestingly, in the twilight hours or if it was a really overcast day. And so his primary care physician referred him to an eye doctor, and they found increased eye pressure, which happens in a condition called glaucoma, and sunlight causes eye pain. So he had to have his glaucoma treated. Here's a slide of functional assessment that shows an undifferentiated function. So when you see this, think of the possibility of a medical problem. And I owe this case to the late, great Dr. Jose Martinez Diaz. And he presented a case of this very puzzling disruptive behavior in a teenage girl with intellectual disability. And it had undifferentiated function. But Dr. Martinez Diaz wisely did scatter plot data and found a very unusual pattern. The problem behavior only occurred in certain rooms of the school and the home, and didn't appear to be related to any task demands or persons within the room. It was related to whether or not the lights were on. And so when inspecting the rooms, there was a commonality. All had old, rapidly flickering fluorescent lights. And neurologists know that that kind of rapid flickering can trigger occult seizures that can manifest as behavioral outbursts. So neurological workup showed that that was exactly what was happening with this girl. So they replaced the lights, treated the seizure disorder, and the condition improved. Here's an example that I wasn't directly a part of, but I knew the team who worked on this. And they had a 20-year-old client with Down syndrome who needed cataract surgery for both eyes. And because of the medical issues this young adult had, the surgeon wanted to do both eyes at one time to limit the amount of anesthesia exposure. But this client also had a history of picking at sores, ripping at bandages, and there was real concern whether they would pick at their eyes in the recovery process, which could really damage the surgery. So a team of an occupational therapist and BCBA got together, and they developed this plan. So the OT suggested that this person wear a fencing mask after the surgery because it latches in the back, and the person really didn't have the fine motor skill to undo that kind of backlatch. And so the fencing mask really protected the eyes. And the BCBA observed that this person liked to do a little bit of crochet, but didn't know how to do that much. So before the surgery, they shaped up their crochet skills to keep their hands busy, differential, behavior. And this combination really worked. There was very successful recovery. And then here's an example of a young child with autism who was just making very slow progress in ABA, especially in skill acquisition. And she was falling asleep all the time during sessions. So, exploring this, they found out that parents were on eggshells with this little girl who was just insistent on screen time and electronics and would have huge tantrums. So, she was typically staying up till 3 or 4 in the morning and then was exhausted during the day. And the parents weren't, they had to be trained to be empowered to successfully limit her screen time and save it as a reinforcer. So this little girl had an effective behavioral sleep treatment. And I will refer you to the Behavior Analysts article of Jin Hanley and Blue. Actually, I think it's in Java in 2013. So they did that sleep treatment. They empowered the family to know how to limit this little girl's screen time and occasional low dose reinforcement. And this is not her actual data, but she actually did make dramatic progress in ABA after that when she was getting enough sleep. Sleep, we all know, is very important. And sleep problems can be caused by health issues, and sleep problems can result in health problems. One condition that can cause a sleep problem is obstructive sleep apnea, when something's blocking the airway. In little children, this may be enlarged tonsils. So here is at the bottom of the screen is a drawing of an oral cavity, and the tonsils at the back of the throat, these are normal in size. But if children have overly enlarged tonsils, what we call grade 4, they can actually meet in the midline and touch the little structure hanging down called the uvula. And that amount of obstruction, often they're going to need a tonsillectomy. There's a neurological syndrome, central hypoventilation, in which the brain respiratory centers forget to, during sleep, to tell the person to breathe. A neurologist would have to handle that. There's restless leg syndrome, which can be from iron deficiency, and treating the iron deficiency can help decrease the restless leg syndrome. You can have nighttime seizures of various types. Extreme obesity causes sleep problems. But interestingly, if the child starts out with sleep problems, it increases the risk of gradually developing obesity. And not surprisingly, sleep problems cause stress in the child and stress in the family. So addressing those is really important. And that brings me to the topic of melatonin. There is I'll give you this reference here of the scientific efficacy that melatonin does decrease the time to fall asleep and increases the overall sleep time. And this is true for both children and adults and for individuals with developmental disabilities. Both children and adults can start, a typical starting dose might be 1 to 3 milligrams, and that may not be enough for a while, but the dose can be titrated up pretty readily to 10 to 15 milligrams as needed, and sometimes more. And if they're taking, say, 5 milligrams at bedtime and they fall asleep, but they wake up in the middle of the night, they could repeat another 5 milligrams. It takes about 20 to 40 minutes to work. And there's this risk of tolerance. It means over time, if they're using it every night, the melatonin may start to become less effective. But the nice thing about melatonin as a medication is it does not fundamentally alter the normal healthy architecture of sleep, and unlike most other sleep medications. And the topic of medications brings us to pharmacology. So Sprague and Weary published, and the references in your reference list, a classic article about what are the ethical guidelines that we should be employing when psychiatric, psychotropic medications are being prescribed for individuals with developmental disabilities. And these were the principles that they suggested. You want to select medicine that has had adequate clinical trial research with the appropriate populations and appropriate behaviors, and inform the family and staff of possible side effects, and also be aware of placebo and what we call temporary or honeymoon effects. Ideally, there would be blind observers obtaining data on the target behavior. And if possible, if you want to leave other interventions unchanged, because you want to decrease confounds to get a better judgment of whether the medicine is really effective. So in the fall and winter of 2006, this is such an important issue that the whole issue of behavior and social issues journal was dedicated to looking at psychotropic medication use in persons with autism and developmental disabilities. And what they found was there was evidence presented in multiple articles in this issue that too many psychotropic medications get used too often or for too long in these special needs populations. And they're not always successful in the target behaviors. But the evidence also shows that sometimes these medicines are really essential and helpful. And that's especially true if there are comorbid psychiatric diagnoses. And I'll give the example. I was a consultant with Dr. Marjorie Solomon's study at the UC Davis Mind Institute on treating well-documented and diagnosed anxiety in children with autism. And we did find that sertraline, which is Zoloft, and SSRI, was very helpful in reducing anxiety in individuals with autism. So we have two valid points of view, and the way behavior analysts can be really helpful is to help clearly define target behaviors for the prescribing doctors and staff and collect data, share it, analyze the functions of behavior. And in this way, we're really creating a team. So our second key word for your CEU is the word for, F-O-R. And moving on. So here's an example of a collaboration regarding medication. And it was a study published in JABA by Kelly and colleagues, and it involved he was about 11 or 12-year-old boy with some degree of intellectual disability and a lot of hyperactivity and problem behaviors. The psychiatrist had prescribed an amphetamine medication approved for treating ADHD and wasn't sure if it was really doing anything. So this very clever study was designed. It was a double-blind analysis that looked at, the other thing I should mention about this boy, he had a lot of communication deficits. So Kelly and crew did functional communication training first, and then they did the study and they looked at where this young man allocated his behavioral responses when he was on the medicine or on placebo. And then when they unblinded the study, you'll see in all three graphs, the pattern was very clear. On the drug, destructive behavior, essentially zero. Off the drug, it spikes every time. The second graph, compliance per minute. On the drug, way high. Off the drug, drops down way low. Very consistent pattern. And the third graph, percentage of reinforcement earned as compared to destructive behavior. And reinforcement was earned also for functional communication. So much more reinforcement on the drug, and destructive behavior low. On the placebo, reinforcement earned goes way down, destructive behavior goes up. And again, a very consistent pattern. So I thought that was a very clever study in this nice collaborative teamwork between behavior analysts and the psychiatrists. And speaking of ADHD, it turns out a lot of our clients with developmental disabilities also have symptoms of ADHD. And in fact, a review showed that about 38.5% of people with autism also meet the diagnostic criteria for ADHD. And interestingly, there's some research that shows that kids with autism who have these hyperactive symptoms often respond to the ADHD medications in much the same way as children without autism who have ADHD. But as is true for most persons with a developmental disability, something about their metabolism is they're often much more sensitive to these medications. So you have to start lower and go even slower than you otherwise would with a typical child. And and another handout just to let you know if you want to learn more about ADHD. I did a brief one-page handout, and these are, of course, the main symptoms as defined in the Diagnostic and Statistics Manual 5. And I'll refer you to the handout for some more information. I want to move on in the pharmacology emphasis to talk about atypical antipsychotic medicines, because I see these prescribed quite a bit for individuals, especially with autism, because there actually is an approved FDA indication for these two antipsychotics, Risperdal, which is risperidone, and Abilify, which is aripiprazole. And the indication is for agitation and irritability in individuals with autism. And not surprisingly, when kids with autism get really irritable, they can get aggressive. So these medications are often prescribed in that kind of context. Now, interestingly, Tyrer and colleagues did this study comparing Haldol, which is an older antipsychotic, with Risperdal and placebo, and they did show there was reductions in target behavior in all three conditions. But interestingly, the placebo group had the largest decline in aggression. And I wanted to point out that Haldol, which is fortunately used less often, is sometimes needed, but used less often in the populations with the behavior analysts often serve, Haldol decreases learning capacity and memory. And this has been shown in experimental animal research and in humans. So unless they really need it, that's a good one to avoid. Now, I've had some experience prescribing Risperdal, and I've also followed children who other physicians have prescribed Risperdal, and it's not always effective. Sometimes it needs to be weaned off, but when it works, it can be really effective. And I had this ABAB kind of clinical trial with a boy I was treating. He was high functioning autism, but just all over the place, no executive function, no organizational skills. He would get wild and unmanageable. And just a low dose of Risperdal. And oh my God, he was a different child. He was cooperative, really focused, able to attend to his activities. But at times the mom wanted to try him off it. So we would, and he'd go back to wild man. So it was a medication that really helped his executive function. Yet we know these medications can have some really serious side effects. So they always have to be monitored for. Risperidone, especially Abilify, not as much, can increase appetite, leading to weight gain. And that weight gain can be so significant, it can put them at risk for type 2 diabetes. And I'll be talking more about diabetes later in my talk. Risperdal, especially, can cause breast growth, even in boys, and milk production, even in boys. And that's because of its effect on prolactin hormone in the brain, which affects the breast. Abilify does that to much less extent. So moving on, I want to talk about other emerging areas that behavior analysts are getting into that I think is so exciting and really needed. So we know we have the skills to teach clients how to cooperate with a medical physical exam or a medical diagnostic procedure, how to cooperate with dental exams. We can help diversify and use our skills in a broader consumer basis. And there are so many people who I think could benefit from this. I'll be talking a little bit about traumatic brain injury. We can help patients, any patient, whether typically developing or with a disability, how to comply better with their medical treatments. And there's these references here below, and a number of them are in your reference list, are studies where behavior analysis was used to teach using glucose monitoring devices, wearing hearing aids and glasses or eye patches, tolerating injections, learning to swallow pills, and so forth. I had the great experience of participating with Dr. Tony Biglin. He's a research psychologist at Oregon Research Institute and a behavior analyst. And he founded this nonprofit called Values to Action that uses the concept of an action circle to get some meaningful work done on targeted problems. And the action circle that I joined with him, these are short term, kind of goal oriented circles. And for 3 months, a group of us worked on what can we do to help improve healthcare for persons with developmental disabilities, intellectual disability, autism, and so forth. So our 3 months of work resulted in this healthcare guide, a guide to improving healthcare. And we published this guide, and we're very proud of it. And it covers, things like how behavior analysts can help prepare persons to have a medical exam or a dental exam, and covers other typical fare that we know as behavior analysts we can do. At the end of our guide, we also reviewed some wonderful integrated healthcare systems that work regularly with behavior analysts. This includes the Kennedy Krieger Institute, Marcus Autism Center, New England Center for Children, Seattle Children's Hospital, Boston Children's Hospital, and others. So I'd really like to see this grow. So needed. Here's the front page of our guide. The website for the guide, you can download it, is in the website handout that you're getting. We also, another work product that we did was this one-page flyer that a behavior analyst or their ABA company could use to go to your local doctor or dentist that you know, or a healthcare clinic, a dental clinic, hospital, and give this flyer to show this is how we can help improve healthcare for your patients. And here are some research articles that document that behavior analysts can help patients cooperate better with physical exams. So Kuvo and colleagues, they did a task analysis and broke down the physical exam into 10 steps. Cavallari and colleagues, they broke down the physical exam in 12 steps. And then they systematically taught their clients how to cooperate with those steps using the technologies and evidence-based procedures we already know, things like preference assessment, prompts for success, fading the prompts when needed, contact desensitization, so where you gradually fade in aversive stimuli, shaping, escape extinction, differential reinforcement. You can reinforce other appropriate alternative behaviors instead of refusing and resisting the exam, modeling. And both these studies show effective results. And I mentioned I would give you a scientific study to build on the one case example from Michelle Wallace. And actually, this is one study by Rishling and colleagues published in JABA, where they evaluated non-contingent reinforcement to increase compliance with wearing foot orthotics, foot braces, and with wearing hearing aids. And they had 100% success after just a few sessions. And they also showed the behavioral skill was maintained. Here are a couple of references in your reference handout about increasing compliance with taking medications. And you have to, of course, first understand the reason for the non-compliance. Maybe the child doesn't know how to swallow pills. Maybe a person's forgetful. Maybe they're worried about side effects. Maybe they're not motivated. All of these things can be worked on behaviorally. And I want to point out an environmental manipulation called the Medi straw. This is a special straw with a little shelf where if the pill is small enough, you drop it onto the shelf. And then when the client takes a sip of fluid, water, whatever, it suspends the pill and it's much easier to swallow. And then I know of ABA, a company that taught a child to swallow pills by first having them suck on Tic Tacs till they were really small, and then learn to swallow the Tic Tacs first. This is a wonderful example that I became aware of through my consulting at the UC Davis Mind Institute. There was this neuroscientist, Dr. Mark Shen. He was trying to do MRI studies on children with autism in all ranges of function, from high functioning. He wanted to get down to very severe, low verbal, low functioning to get a full range of data. But the problem was, especially for these low functioning clients, they moved around so much the data was worthless. But his wife turned out to be a BCBA. She was consulted, and she very cleverly, they did some mock MRI preparations, and they shaped the children's behavior. So the children learned that they set it up with the MRI. They could watch their favorite video during the MRI scan, but only if they stayed totally still. So the video watching was contingent on staying still. And they were 100% successful in getting all those children imaged with good data. I told you I would tell you more about diabetes, and diabetes is a very important topic. It's the seventh leading cause of death. There's both type 1 and type 2. And I'm not going to get into the details of the differences. But we know a patient with diabetes, whatever type they have to change their behavior, and they have to maintain good behaviors over their lifetime if they're going to have good control. Counting carbohydrates, self-monitoring their blood glucose, which is their blood sugar, adjusting their insulin dose. So here's this wonderful reference article by Dr. Bethany Rafe and colleagues in Behavior Analysis and Practice. It's so informative. I highly recommend that if you're interested in doing behavior analytic work with patients with diabetes. And what Dr. Rafe and colleagues did was they conceptualized diabetes poor management as a combination of behavioral deficits and excesses. Makes sense, right? So they looked at antecedent and consequence interventions, multi-component interventions, some alternative approaches that I can't go into detail on were some alternative kind of internet-based things. And excesses would be things like overeating or eating too many carbohydrates, being too sedentary, smoking, excessive alcohol, all can have a horrible effect on blood sugar control. And then the deficits would be if the patient's not checking their blood glucose often enough, or they're not adhering to their medications, or not exercising properly. So here's some references, and they may not be in your reference list, but if they're in Dr. Rafe's article, and her article is in your reference list. So some of the antecedent-based strategies, here was a multiple baseline design across diabetes care behaviors. They looked at urine testing, foot care, and diet. It turned out that a written memo with a vocal prompt did increase compliance for this 9-year-old girl with type 1 diabetes. So increased compliance for her dietary tasks. But they had to add, the addition of contingent points exchangeable for tangible items to help improve her urine testing and her foot care. But it was successful. And this was a consequence-based strategy for diabetes in this pilot study by Rafe and Dallery. And they looked at 4 teens with poorly managed type 1 diabetes. And they did this internet-based contingency management in which the teenagers earned money for each self-monitoring blood glucose test they did, up to 8 times a day, which is often recommended, but they needed to meet the minimum of at least 4 tests per day. And to document they were truly checking their blood glucose, they either recorded their video of the process or they showed a log from their glucose meter. And there was a brief ABA reversal design, and it showed that it was effective. How about diversifying? I mentioned that earlier. This hallmark article on this is by Dr. Linda LeBlanc and colleagues. So and it's in Behavior Analysis and Practice. So if you really want to diversify, I would say go to this article first. And they give Jennifer Bosca Esther 2024. Sorry, my sister has a disability. Jennifer, I can't talk. I'm giving my talk. Bye. Sorry about that. Usually she's very good about not calling when I've instructed her. So Linda LeBlanc and colleagues, they talk about like expanding to elderly or dementia patients, acquired and traumatic brain injury. And there's a huge population that could really benefit from our skills. Jennifer, I can't talk. No, please don't talk to me. Don't call until about 11. Okay, please. Thank you. ABA for health coaching and fitness. So a hallmark article on this would be from Matt Normand. And why is it important? Well, we know about 50% of the US population has chronic disease that could be prevented or at least improved by behavior changes. And if we want to diversify in this, we could consider becoming a health coach. Health coaching is an emerging field. It's not a science per se, but more a field. And here's a great article on that. So health coaching, when you look at the research from De Jong et al., the efficacy is promising but variable. And I feel behavior analysts have the skills to increase the efficacy. But you want to follow like LeBlanc's and Norman's guidelines to gain the skills you need, the experience, the credibility. Often that means a mentor and checking the literature. Ultimately, you may want to start your own health coaching agency. And I did meet online a Dr. Sarah Burby who did just that. And she's making a very successful living as the BCBA health coach. And I'm going to be talking with her further, but I don't have details on that right now. So read the professional literature and if need be, become part of relevant groups. So one relevant group would be with the American Council on Exercise. They have this credentialing program to be a health coach. They identify the skills needed to be a health coach. And not surprisingly, a lot of those skills overlap quite a bit with what we as behavior analysts professionally are trained to do. And finally, I want to recommend this book on successful adaptive and lifestyle changes to promote good health, Living Smart, 5 Essential Skills to Change Your Health Habits Forever. Doesn't mention behavior analysis at all in the book. That is all very behavior analytic. I actually met and worked a bit with Dr. Sherry Pruitt. She's a clinical psychologist, strongly trained in behavior analysis. She was hired by Kaiser, Northern California, for the adult medicine program, and she updated their entire health education program for Northern California Kaiser based on behavior analytic principles. And with that, I want to thank you very much. And my sister Jennifer thanks you. And let's see if there's any questions.
Yes, thank you so much, Dr. Copeland. That was wonderful, just a wealth of knowledge that you have from your experience. So yeah, we have a couple minutes. If anybody has any questions for Dr. Copeland, you can put them in the chat or you can put them in the Q&A. And while we're waiting for that, if you don't mind stopping your screen share, I'm going to pull up one more last screen.
Okay, let me do that. Okay.
Okay. Oops. Let me get back. Okay, let me get my chat back up because I can't see it right now. Make sure didn't miss anything. I don't see any questions there. There's somebody raised their hand. Okay, here we go. Any recommendations on how we approach increased appetite with a client on Recepidol, if I said that correctly, or do we allow them to eat as wanted? Currently working through this with a family. You want
A very important question. No, you don't want the client to eat anything they want. Hopefully, if you can proactively, even before they're going to start Risperdal, start shaping their dietary choices and their serving portions and so forth. But that's we often have the clients come to us and they're already on Risperdal and they may already have an increased appetite. So it's important to the level that the client can understand and give assent, and with the family to really counsel them on appropriate portions and healthy food and avoiding, excessive fatty, greasy foods and, a lot of ultra processed foods, a lot of high sugar content. Um, and if need be, there may need to be environmental restrictions with locks on food cabinet doors and the refrigerator if needed. And consult with the healthcare provider who's prescribing the Risperdal. And there are some medications, the names of them don't readily come to my mind, that can be given to help decrease the appetite, especially if they're really benefiting in other ways with their behavior and executive function from the Risperdal. But you definitely want to control how much they're eating so it's healthy proportions and healthy food.
Wonderful. I see a bunch of questions about the last keyword. I'm going to give that to you in just a minute. We're going to answer one more question, and I promise I'll give that last keyword in the form. So, last question we have, is there a place you'd suggest for literature supporting ABA for other diagnoses? We often have requests for insurance, and they will not cover service for other diagnosis. Sorry, I'm using diagnoses on there.
Okay, our healthcare guide that you can download from the Values to Action website may have some references that will help you with that. Um, I can tell you for the state of California, where I actually do consulting work for a health insurance company. It's a managed care health insurance company, and we're regulated by the California Department of Healthcare Services. And we got a mandate from the state that legally we have to follow that has specifically said that ABA cannot be restricted just for an autism diagnosis. You have to look at, is there medical necessity based on the person's behavioral excesses and deficits? And if you can show medical necessity, then it should be a covered benefit, at least for those managed care plans regulated by that. So there is a growing movement to increase access for these other diagnoses, and we'll just have to keep working on that. I over the history of my career, I saw where previously ABA was not covered by health insurance at all, and families had to fight for it. And there was a movement led by like Dr. Gina Green and by the attorneys, Lori Unum and her husband, a movement across the country to go state by state, and we kept track of which states, started getting insurance laws that said insurance had to cover ABA for autism. And maybe we need a similar movement to really expand what we can do. I hope that's helpful.
Yes, absolutely. Thank you. Thank you so much. Well, the last keyword is impact. If you want to learn more, you can check out our website and book a demo to see how our platform can help you. You can also connect with us on social media and stay up to date with our latest webinars and free resources. Please also don't forget to complete the form in the chat to earn your CEU. I hope everybody has a great day. Thank you for joining us to learn and grow together. Thank you so much, Dr. Copeland, and thank you everyone for being
Thank
here
you.
today.
Thank you all. Thank you so much. Bye.
Bye.